Although I'm not a research nurse myself, of course, I work alongside our clinical trials team. And of course, Dr. Follows is well known within the clinical trials sort of scene, really. So it may be that patients have been referred into us specifically because they know that, we're very much a research facility, that Dr. Follows heads up our trials team. Or it may be that the idea of trials is first introduced by us to sort of say, well, these are potential options, but obviously having to make it very clear that, there are very strict criteria and that all of this needs to be looked at. So we may be able to say, then you might be a candidate for potential trial, but we would have to look very specifically at what inclusion exclusion criteria. But I think, again, it's arming the patients with that information and then saying to them, these are potential trials that are around, and even if we're not running them, but actually you look like you very much might fit the criteria, and we would think that that might be something very beneficial. Making sure that patients know where they might be able to access that, even if it's not through us. Or it might be if they're in that journey where maybe they have relapsed and getting more refractory disease, and actually trial options should really, really be considered as another option for a patient, making sure that actually we're very open with them to sort of say, these are potential trials around and these are key contacts. And in some ways, I think Dr. Follows will very much act as an advocate, and he is always happy on a patient's behalf to write to another clinician who's heading up a trial to say, I've got this patient, very difficult disease, trial may be absolutely worth considering. Would you see this patient on our behalf? I would hope it's not better care. I think from a patient's perspective, it may be that there's more visits to the hospital. So from a patient's perspective, it may feel that they may be more closely monitored, but a lot of that can be driven by the requirements of the trial. But perhaps from a patient point of view, they may feel very safe because they're being monitored on a more frequent basis. Of course, that may have downsides for the patients because they're having to make more trips in and out. And of course, they have their designated trials nurse who in some ways will have a smaller caseload of patients than perhaps those of ourselves, specialist nurse, looking after patients not on trial. And I think the other thing to make sure that the patient has is obviously the trials team will be looking after that patient in the context of trial and want to meet all the needs of what's required for that patient on trial, but making sure that they also have that extra layer of care to sort of say that these are all the supports that you need, and in addition to what's required from the trial perspective. But I think it's just that, they will have very close monitoring. Quite often as well, it can be that they maybe see the consultant on a very regular basis because it may be that the consultant is leading that trial or is the designated trial person. So I guess from that point of view, they may feel that yes, that they're very well cared for and that they have very ready access to the sort of consultant trials team. It's looking at what's right for particular patients, and for some patients, trial may not be the option, they may not meet the criteria, but I would like to think that any of our patients not on trial, we are offering as good a treatments as we have, and that in some ways the level of care we will provide will be to support that patient, as much as possible going through their treatment so that they're not at disadvantage if they're not in trial.